Okay. So there's some specific infectious disease syndromes which are common and will reinforce some of the things I've been talking about. Asymptomatic bacteriuria, skin and soft tissue infections, pneumonia, and C. diff. So here's a good paper, a really interesting paper. I should say these papers have been written since the 1960s, but here's a more recent one. It talks about pyuria, in other words, white cells in the urine, bacteriuria, germs in the urine. It's common in older women. It may be asymptomatic or it may be symptomatic, they could really be sick, or asymptomatic. And you have to somehow figure out between the two, because asymptomatic bacteriuria doesn't need to be treated. It doesn't cause clinical problems, and treatment engenders adverse drug reactions, multiple drug-resistant organisms, and C. difficile. At the meeting in California a couple of days ago, I was sitting there eating lunch, and this old man, maybe older than I am, sat down next to me, David Gilbert, who used to be the president of the Infectious Disease Society of America. He's a great clinician, and we started talking about different things. And he said, whoever said that a urinary tract infection makes an older woman confused? Where did that come from? That was his wisdom. So there's this indiscriminate urinalysis and urine culture business and treatment for vague symptoms. So this happens so often. This is what Dr. Gilbert and I were talking about. And you've seen it. Either your mother or your grandmother or your patient says, and you may say as their spokesperson, my grandmother, she's not doing well, and she's not eating well, and she looks tired, and she's weak, and she looks like she's uncomfortable. And her mentation somehow, she's already demented, is worse, and her urine doesn't smell good, and it's cloudy, and it's yellow. Does that strike anybody? Whose urine smells good? But that's what they say, the urine doesn't smell good. And this is not necessarily a urinary tract infection. So to counter, what does this mean here? All right, so there's a problem. This slide may be a little bit out of whack. So the CMS, which means Medicare and Medicaid, they penalize hospitals, and for that matter, us as clinicians, when a patient catches a urinary tract infection in the hospital. It's called, a nosocomial infection, a hospital-acquired infection, and to counter that, hospital administrators say, we're smarter than the feds. We're going to do a urinalysis and a urine culture on every patient that comes through the emergency room, every patient that's admitted, and we'll show that there's already germs in the urine, already white cells, and they're not going to ding us for a hospital-acquired infection. And that's an enormous problem that we have to deal with. So how do you proceed then in regards to this symptomatic or asymptomatic bacteriuria? So this JAMA article has a nice algorithm which is too complex to put on the screen, too many arrows. But if a patient has new or worsening dysuria, so that's the key word, dysuria, it hurts when you pee, frequency, and burning, that's a red flag for perhaps a real urinary tract infection. But on the other hand, you can have dysuria, especially in an older woman, which by definition has atrophic vaginitis. It may burn and sting. And you ask them, they say, yeah, I've had it, but it's been going on for 30 years, ever since menopause when I was 40. So, but dysuria is something, especially in a younger woman, it's usually women, who has frank dysuria, that's a urinary tract infection. And then fever and leukocytosis, that's an infection. Then you do a urinalysis, then you do a urine culture. But for these non-specific symptoms, you avoid a urinalysis, avoid a culture, and avoid treatment. And there were people getting much more excited than I in California last week trying to drive this home. And this is the major reason for antibiotic abuse, is asymptomatic bacteriuria. And the Infectious Disease Society of America says screening for or treatment of asymptomatic bacteria is not appropriate and should be discouraged. So out in right field there, you tell the lawyer, you just show them the guidelines, you say, that's why I didn't do it. And then you deal with the legal system. So skin and soft tissue infections, very common. Cellulitis. It can be broken down into two categories, if you will. Just reddened skin, it's usually on the lower extremity, for example, which is not purulent, or it could be purulent. So for non-purulent cellulitis, it's usually group A strep, sometimes group B strep, a major enemy of diabetics, sometimes group C strep, and this responds to beta-lactams, you know what I mean, penicillins and cephalosporins. It may well respond to clindamycin with the advantage of toxin inhibition. And I mentioned to you before, the oxalidonones also have that quality. So often, you and other physicians will give Bactrim or tetracycline. The reason you do that is because you think that this cellulitis could be caused by Staph aureus and MRSA in particular, because everybody thinks MRSA. First of all, it doesn't. It's not caused by Staph aureus in most cases, but it's not purulent. And what I want you to understand now is that Bactrim, trimethoprim sulfamethoxazole, TXS, probably doesn't work against strep. And for that matter, tetracycline or doxycycline, which is used commonly for cellulitis, doesn't work. So you've got a patient who's reasonably sick, and you're giving him an antibiotic that doesn't work. And that happens so frequently, so I want you to know that. On the other hand, if you have purulent cellulitis, like the skin is reddened, but there's boils there, and then there's pus, then it may well be Staph aureus, and for that matter, MRSA, and then you have to treat for MRSA, as we discussed in the first hour. But how good can you tell the difference between strep and staph? Besides this simple breakdown of non-purulent and purulent. Well, it's not that easy. It's easy for me to say, sit here and tell you that, but in confirm with the patient, it's not that easy. So you could use an antibiotic that covers both. Clindamycin covers both MRSA and most strep. That's one way to do it. Some physicians are using a penicillin, a beta-lactam for the likelihood of group A strep, and then they're adding Bactrim or doxycycline for the possibility of MRSA. So they're leaving the emergency room, let's say, on Keflex and Bactrim. I see that a lot. It is not unreasonable. But this is a very common thing, but I just want you to know that Bactrim and tetracycline don't work for strep. Gram-negative rods, GNR, gram-negative rods infrequently cause cellulitis, so there's no reason to treat for gram-negative rods. Once again, I said half humorously, but much more seriously, everybody gets vancomycin and zosyn who comes through the emergency room for cellulitis, for everything. But this is one situation where they don't need the piperacillin, tazobactam, and the zosyn, because gram-negative rods are not an issue. And almost, if it's rare, we'd be talking about rare cases where gram-negative rod would cause a cellulitis. Now, I've already told you, and I'll tell you again, about bilateral lower extremity inflammation, stasis dermatitis, doesn't need antibiotics. Even if it's as red as the Coca-Cola can that I just tossed, if it's bilateral, it'll be very unusual for somebody to have bilateral infection at the same time, get both legs infected, and statistically it doesn't calculate. So stasis dermatitis doesn't need antibiotics. Abscesses, boils, furrows. Usually just an incision and drainage does the trick, and antibiotics often aren't even necessary. This is based on older data. There were some new papers at California last week that said that maybe antibiotics help after all. But usually just think, if you've ever had a boil or had a patient who had a boil, if you just drain it, it's okay. Pneumonia, acquired in the community, is usually caused by the pneumococcus. And one way to diagnose that is, of course, on sputum. Gram-Stamen culture, but another way would be the urine pneumococcal antigen. That may be a question on your boards. One of these days I guess you'll take boards, and they probably like that question. In my day, the pneumococcus was invariably penicillin resistant. Sensitive, I'm sorry. But now, as time has evolved, it's become resistant. And another common cause of community-acquired pneumonia is what they call the atypicals. That's an official designation, atypicals. And the ones that we're talking about are Legionella pneumoniae, Mycoplasma pneumoniae, and Chlamydophila pneumoniae. And the way you diagnose Legionnaires is by a urine antigen. So how do you treat this? And the guidelines are old, and they may change. But what they say now is you want to use ceftriaxone or Cefin because that is effective against penicillin-resistant pneumococci. So there's one answer. And then you want to use a quinolone or a macrolide for the atypicals. Another way to do it would be to use what they call a respiratory quinolone. If you remember before, there's first-generation quinolone, Cipro, which is relatively ineffective against the pneumococcus. And I had the bad fortune of seeing a physician die of the pneumococcus while on Cipro. But there are higher-generation quinolones, shown here in particular, levofloxacin and moxifloxacin, which are effective, more effective against the pneumococcus, and can be used as a single agent. Because let's say levofloxacin, Levaquin, will get the pneumococcus and will get the atypicals. So back to this difficult question of duration. More and more literature is accumulating that 5 days of antibiotics suffice for community-acquired pneumonia. Some of you might say, well, listen, let's do a repeat chest x-ray to see if the pneumonia has responded, to see if it's gone. Bad idea. Because the chest x-ray may remain positive. It often remains positive for days and weeks, and maybe even 12 weeks, 3 months. Right? So you don't treat it until the chest x-ray clears because they'll be on antibiotics forever, unnecessarily. C. difficile. Talking about common infections, a large part of the meeting in California. I've said that so many times, you must think it was a long meeting. It was. 10 hours a day, for 3 days. Lots of CMEs. But otherwise known as antibiotic-associated diarrhea. I will challenge you. You guys take the Hippocratic Oath, Nikki?
We take a different oath for the PA.
Well, there's a Hippocratic Oath. Everybody knows. Do no harm. But if you cause some C. difficile, that's not good. And the incidence is rising. This is an old slide now, but it keeps on going up. Each year it's higher and higher. I'm going to sort of paraphrase this slide by saying that a lot of C. diff is spread from one patient to another, on a nurse's hands or a physician's hands, for example. But whole genome sequencing has shown that is not always the case, and that the C. difficile may well come from elsewhere. The reason I mentioned this to you, one reason would be that people think that if you have a lot of C. diff in the hospital, that means that people aren't washing their hands. But even if you're scrupulous about that, you may get C. diff from elsewhere. How do you diagnose C. difficile? Well, there's lots of tests. It's generally done now by polymerase chain reaction tests, a toxin assay. You can also smell it. And the nurses used to say, this room, I think the patient has C. diff, I can smell it. And I said, get out, you can't smell this. But in fact, it has a specific odor. It smells like a horse stable. The nurses can tell, and there's a dog, a trained dog, whose name you can figure out if you want, who can sniff out C. diff, and there's the molecule. And the pathophysiology is very clear and easy to understand. Antibiotics eradicate normal flora. Nature hates a void, and Clostridium C. difficile proliferates. And an enormous part of the meeting in Chicago was about the microbiome and how you mess up the microbiome with antibiotics, and then C. difficile proliferates. There are certain patients who are predisposed, or people that are predisposed to C. difficile. It's innate. predisposition is probably genetic, although that has not been worked out. But there are probably people that have a gene mutation such that they're predisposed, advanced age, and immunoglobulin deficiency. There's not too much you can do about that, right? But there are imposed predispositions. An increased gastric pH. So many of our patients are on PPIs and H2 blockers and the like. And now there's an enormous movement to avoid that. I mean, so many of our patients are on Pepcid indefinitely. And that's bad because you neutralize, I mean, it's good if you're trying to prevent an ulcer, of course, but if you're neutralizing the stomach acid, that predisposes to C. diff. So there's a big movement in hospitals now to decrease the unnecessary use of acid production. And then exposure we talked about. Again, exposure in the hospital is one, but you may get exposed if you go to Homeland. And then antibiotics. I mean, here's a question for you. Can you get C. difficile if you're not on antibiotics? No. Right? Based on this, as long as you have a lot of good flora there, if your microbiome is healthy, you're not going to get C. diff. So these next 3 slides I consider key for understanding C. difficile. So here, we talk about cumulative antibiotic exposure over time and the risk of C. difficile, CDI, C. difficile infection in days. So on the vertical axis, you see adjusted hazard ratio, and on the horizontal axis, you see days of antibiotic therapy. So the longer you get antibiotics, the more days you get antibiotics, the higher the risk of C. diff. This is the whole reason, one of the reasons, big reasons why there's this movement to decrease duration. Cumulative antibiotic exposure over time and risk of C. difficile by number of antibiotics. Once again, hazard ratio on the vertical axis, on the x-axis, number of antibiotics. The more antibiotics a patient takes, the higher the risk of C. diff. And the third slide, cumulative antibiotic exposures over time and risk of C. diff. Doses. The more doses you get, the more antibiotics, the more days, the higher the risk of C. diff. So this is the rationale, this is the data, if you will, for not giving antibiotics, or giving antibiotics for fewer antibiotics for shorter periods of time. So how do you treat C. diff? With metronidazole by mouth or vancomycin by mouth. But there's this vicious cycle because you could ask, well, doesn't metronidazole change the microbiome? Absolutely yes. Doesn't vancomycin affect the microbiome? Absolutely yes. So now you're back in the cycle on that previous slide or two. And it gets worse because C. difficile comes back, to a tune of 20% after the first episode and 45% after the, that's wrong, second episode, second relapse. Yeah, I don't, somebody needs to correct this slide for me. Nikki, we got to work on this. And 65% after a subsequent relapse. And I've seen people, older women, I remember one in particular said, I hate this. I've had it 11 times. I want to die. This is diarrhea they've had for months and months. So what do you do for relapses? Well, you limit stomach acid suppression, as I mentioned to you. There used to be these spore-exhausting regimens, which we won't go into because they don't work. There's a new antibiotic out there called fidaxomicin difficid, which doesn't work too well. It's $1,000. IVIG, I mentioned to you that immune globulin deficiency may be an issue, and you can give IVIG. There's another way to do it, bovine hyperimmune colostrum, and then colonization with non-toxigenic spores. People have tried all sorts of things until they came to the answer. So stool transplant, how many are you familiar with that? Is that something you've heard about? Mm-hmm. Yeah. So it's really, as John Bartlett said at an infectious disease meeting a couple of years ago, it's effective, but the aesthetics suck. But it works, all right? So we'll talk about it now a little bit. Usually, you deliver the stool by colonoscopy or by NG tube. And there have been, donor issues, like you don't want to it's a transplant, it's a funny kind of transplant, but still, you're giving something to somebody else. So there's this company called Open Biome, which now has stool, which they take from students from Harvard and MIT. That it happens to be in Boston. I mean, it could as well been in Oklahoma. And they screen these donors very carefully to make sure they don't have HIV and hepatitis B, and they do all sorts of stuff. And the stool is pure stool, and it doesn't have anything else in it. And then they came up with capsules. They said, wouldn't it be easier, instead of getting a colonoscopy or an NG tube, if you just swallow it? And here's a study. And when I got tired of the meeting, 10 hours a day, I went to the exhibits. And I was walking around, and I saw the Open Biome capsule exhibit. And it is now commercially available. Okay, this is a study, but now you can buy a bottle of stool capsules for $625 and treat your C. diff. I don't know what to spare you this, but you can read this later. But what this is a poem that somebody wrote, and what it says is that so often, let's say in the ICU, a patient comes in, they're sick as a dog, and you just don't know what they have, and you give them vancomycin and all the other antibiotics, and you still don't know what they have. And then you come back the next day, and they've got C. diff. Yes, now you've got a diagnosis, now you can treat them. Pretty weird, huh? All right, so the last thing we're going to talk about, because we're going to be done by 2:30 here, is infection control. So that's a big part of infectious disease also. So the 4 issues here are shown: hand washing, isolation and de-isolation, in this business of chlorhexidine bathing and device removal. So here's another cartoon for your humor. And that's the big deal. I mean, if somebody asks you, what do you know about infection control? Just say, hand washing, you're good. That's what you need to know. And here's another cartoon. The patient in the next bed is highly infectious, thank God for these curtains. So a lot of patients, I mean, when I walk through the halls this morning, I just, I can see several patients in isolation, contact isolation, this isolation, that isolation, to try to prevent the germ from getting out of the room on my hands or somebody else's hands and to the next room. So when do you stop isolation? And it's the damnedest thing at the hospital I work at. I said, why is the patient in isolation? They said they had a history of MRSA. And I said, does that mean they're going to be in isolation for the rest of their life? And the answer is yes. That's what they say. But the answer is you can get out. You're allowed to get out. Most of us, a lot of us carry staph and MRSA for that matter in our nose. Like a third of the people here, us, have staph aureus, not MRSA, but regular old MSSA, staph aureus in our nose. It's normal. And a certain number of people have MRSA. But you can get out of isolation with one negative nasal swab. For VRE, one negative rectal swab. But when it comes to these gram-negative rods that we started with at 1 o'clock, these terribly resistant germs, it seems like you carry them pretty much forever. So if you've got an ESBL, you may be in isolation until forever. And how about C. diff? Well, when the diarrhea ceases, then you're allowed out. These are sort of pseudo-studied and pseudo-recommended in the literature. So somebody came up with an idea recently. They said, why don't we just hose down all patients? Everybody that comes in, we're just going to spritz them with chlorhexidine, and they won't be colonized with MRSA and ESBL and C. diff, and then that's cool. And they wrote it up in the New England Journal, and it became very popular. And then somebody did a repeat study, and I'll just read it to you. It said, in this pragmatic trial, daily bathing with chlorhexidine didn't reduce the incidence of healthcare-associated infections with CLABSIs, that stands for central line-associated bloodstream infections. In other words, germs you get from a PICC line, from your skin that gets in. CAUTI stands for catheter-associated UTI, so you have a Foley in, and the germs get in. And it didn't stop ventilator-associated pneumonia, VAP, or C. difficile. These findings do not support daily bathing of critically ill patients with chlorhexidine. And the gentleman here said it may even promote resistance. All of a sudden it becomes resistant to chlorhexidine, and you've got even worse germs. Well, a lot of hospitals are doing chlorhexidine bathing, especially in the intensive care units and dialysis units, and it hasn't been worked out yet. At least I didn't see it. It wasn't talked about in California. I don't know if people are doing this or not. I think I missed that part of the meeting. Device removal. So here's a question. Can you get a catheter-associated UTI if you don't have a catheter? Homer Simpson would say no, right? No, you can't. So it's so important. Try not to, put them in the first place. And if you can, take out a Foley catheter as soon as you can. And likewise for a central line. So many patients, have subclavians, and now they have IVs and midlines and PICCs. But you try not to place them, obviously. But if they need them, you try to remove them as soon as possible. Some patients are resistant, especially an elderly, obese woman in the hospital. She said, "Please leave my catheter in. I don't want to get up to pee." And I said, "How about a bed pace?" "I don't like bed pace. How about a bedside one? I don't want it." I said, "Listen, you got, take this out before you get a cavity." And then central lines, the well-meaning physicians and healthcare workers and PAs will say, "Well, let's leave this line in just in case we need it." And it was somewhat of an ordeal to put it in. Let's leave it, for a couple more days in case you need it. Bad idea. Because the longer you leave it in, the higher the risk of collapses. Well, good luck in your career. If you have any questions, I'd be happy to answer them. Otherwise, have a nice weekend.